My talk is on usefulness of triple H therapy in subarachnoid hemorrhage. I request all the delegates to fasten their seat belts as we are going to have plenty of U-turns en route this presentation. I can see that you are already look a bit twisted with the 2 U-turns that you made post lunch, but there are more U-turns on the way. But I would like to assure you here that 2 U-turns doesn't bring you to the starting point. There is still a way forward in these U-turns. Okay. So before actually going into the utility of triple H therapy in our current day practice, I'll just briefly touch upon the basics of subarachnoid hemorrhage. Apologize me if I look like rushing through the slides. Yes, subarachnoid hemorrhage is the 4th most common cause of CVA after atherothrombosis, embolism, primary intracerebral hemorrhage, but the most disastrous one. 10 to 15% of them do not even reach the hospital, with another 25 to 30% dying within first 2 weeks. And in those who survive, 50% do not have good recovery. Okay. And most common cause of this is ruptured aneurysm. Another 10% it is perimesencephalic non-aneurysmal subarachnoid hemorrhage. It's a venous bleed and it doesn't take that rough course as ruptured aneurysm. Another 5% is because of AV malformations, congenital syndromes like Ehlers-Danlos, alpha-1 antitrypsin deficiency, inflammatory lesions like mycotic lesions, Behçet's, hematologic diseases, trauma, tumors, drugs like cocaine, anticoagulants, all these can cause, but it's ruptured aneurysm that's most common cause of subarachnoid hemorrhage. Yeah, how does this happen? Most of the aneurysms occur in the first half of the anterior half of the circle of Willis at the branching points of the major vessels. As you can see, the left internal carotid artery is branching into left anterior cerebral artery and left middle cerebral artery. This is where there is hemodynamic stress, which puts stress on the arterial wall, causes it to bulge out like an aneurysm, and subsequently some thinning happens, and when there is high pressure, it tends to burst at the dome of the aneurysm, causing leak into the subarachnoid space. Well, as you can see, the blood usually goes to the cisterns, sylvian fissures, and interhemispheric fissure, sometimes even breaches into the ventricles. How do you go about it? There are 2 options, surgical and endovascular. In surgical, you do the craniotomy, then identify the aneurysm, apply temporary clips, and then the permanent clip. When it comes to coiling, you go percutaneously, reach the aneurysm, put some coils into it. There are few scales to assess the severity, Hunt and Hess scale, which takes into consideration the symptoms as well as motor deficits. World Federation of Neurological Society scale, which takes into account GCS and motor deficits. But here I would like to highlight the modified Fisher grading score in the context of DCI, that is delayed cerebral ischemia, that we are going to talk about. It has 5 grades: 0, no subarachnoid hemorrhage, and no intraventricular hemorrhage. The risk of DCI is negligible. 1 to 2, very thin diffuse focal subarachnoid hemorrhage. With IVH it is 2, without IVH it is 1. The risk of delayed cerebral ischemia ranges from about 10 to 30%. Grades 3 and 4, where it's a thick diffuse or focal subarachnoid hemorrhage with or without intraventricular hemorrhage. With intraventricular hemorrhage it is 4. The risk of delayed cerebral ischemia in grade 4 goes as high as 40%. Complications: post aneurysm rupture, these patients can have rebleeding, seizures, hydrocephalus, cardiac dysfunction, fever, and hyponatremia. But the most dreaded complication that gives nightmares to the intensivist is delayed cerebral ischemia. Let's get familiarized with these 2 terms, vasospasm and delayed cerebral ischemia, which are commonly used interchangeably, but they are not. Vasospasm is actually arterial narrowing after subarachnoid hemorrhage, demonstrated by radiographic imaging or a sonography. So it's a radiological finding or a sonographic finding, not a clinical finding. Whereas delayed cerebral ischemia is occurrence of neurologic deterioration like hemiparesis, aphasia, altered consciousness that is not owing to other causes, or evidence of new infarction on CT imaging performed more than 72 hours after the aneurysm rupture. Okay, it is recognized as main cause of substantial disability and death, incidence as high as 70%, killing about 7% of patients and causing severe deficit in another 7%. It usually doesn't occur before day 3 and has maximal incidence around 6 to 8 days and rarely occurs after 7 to 21 days. Coming to causes of delayed cerebral ischemia, it is still unclear, and as a result we think it's multifactorial. The importance of this slide is, apart from vasospasm, there are various other reasons of delayed cerebral ischemia, like cortical spreading depression, inflammation, and intravascular microthrombosis. So what I would like to emphasize is there are several cases recorded where you have severe vasospasm, but there is no delayed cerebral ischemia, and vice versa is also true, where there is delayed cerebral ischemia without vasospasm. Now, coming to this topic per se, the triple H therapy. The three components are hypervolemia, hypertension, and hemodilution. And this has remained the standard of care for the past 3.5 decades or so. In fact, during our post-graduation days, there was no way that you could escape this triple H question. If you don't get it in theory, you will get caught in long case. If not, at least in table viva. There is no way that you can get away without triple H therapy in your exams. Such was the standard of care. How did it all start? This was following a publication in Journal of Neurosurgery in 1976, where Kosnick and William Hunt have reported 7 cases of delayed cerebral ischemia post-clipping, and all of them have been recovered with hypervolemia and induced hypertension. So 2 H's were introduced in 1976. The third H was added by Wood in 1982, and he observed that in 9 cases of subarachnoid hemorrhage, with hemodilution he could avoid symptomatic vasospasm. So what happens in, what's the pathophysiology on or assumption on which this 2 H's have come, first 2 H's. Initially when there is subarachnoid, normally the arterioles are the resistance vessels in the brain, but with subarachnoid hemorrhage, this resistance shifts to more proximal vessels or as close to circle of Willis. As a result, the auto-regulation is lost and these vessels become pressure dependent. So how to overcome this resistance? They thought the only way is to increase the cerebral blood volume and by induced hypertension. So coming to each individual components of triple H, initially all subarachnoid patients in the first 3 days at least are hypovolemic, secondary to aneurysmal bleeding or hypothalamic dysfunction or natriuretic peptides. So hypervolemia was achieved with crystalloid or colloid solutions, and volume expansion was done while monitoring filling pressures like CVP, and in those days even pulmonary capillary wedge pressures. Coming to hypertension, as already discussed, there is disruption of autoregulation and cerebral blood flow becomes pressure dependent. But in all these decades, there are no definite goals for BP. Some are using systolic blood pressure, some are using MAP. Well, on the whole, in majority of the times, they used MAP 15 to 30% above the baseline, and whenever there is a vasospasm, hypertension was induced with noradrenaline or sometimes with phenylephrine. Coming to hemodilution, the logic was that according to this Poiseuille law, flow is inversely proportional to viscosity. So assumption was that when you reduce the viscosity, flow increases. So they believe that with hematocrit of 30 to 35%, both flow and oxygen requirements will be met. Now, the standard of care which we thought has been lasted for 35 years, we expected to be supported by a lot of evidence. Well, I was very much surprised when I was doing that there is hardly any literature actually supporting it, or when I say literature, randomized controlled trials. This study, which was published in Critical Care 2010, is a systematic review of effect of different components of triple H therapy on cerebral perfusion in patients with aneurysmal subarachnoid hemorrhage. Well, apologies for this. They reviewed about 170 articles, of which they found 14 original articles, and of them 11 have met the selection criteria. You can see that only one of them is a randomized. You don't see the. Received significantly more fluid and had higher pulmonary artery diastolic and central venous pressures than normovolemic patients, but there was no difference in mean global cerebral blood flow. That is what we want to increase, isn't it? There is no difference in mean global cerebral blood flow during treatment period between hypervolemic group and normovolemic patients. Yeah. Now, this is Neurocritical Society's guidelines. The Neurocritical Care Society has actually organized a multidisciplinary consensus conference to develop recommendations for the critical care management of patients following aneurysmal subarachnoid hemorrhage. They involve neurosurgeons, neurologists, interventional radiologists, and neuroanesthetists from Europe and US. They reviewed the literature and graded the literature and come up with recommendations as per grade system. So some questions were addressed. I just picked up the questions relevant to our triple H therapy. The question that was addressed was, should prophylactic hypervolemia be employed in the management of subarachnoid patients? So the answer is, or the recommendation is, intravascular management should target euvolemia and not hypervolemia, and there is evidence for harm from aggressive administration of fluid aimed at achieving hypervolemia. High quality evidence and comes with a strong recommendation. Now, American Heart Association and American Stroke Association have also come up with guidelines. This was published in Stroke 2012. So, according to them, the maintenance of euvolemia and normal blood volume is recommended to prevent delayed cerebral ischemia. Class 1 recommendation. Prophylactic hypervolemia or balloon angioplasty before the development of angiographic spasm is not recommended. Coming to second H, hypertension. Very surprising, only case reports, observational studies and prospective case series. Yes, there may not be randomized control trials because, as Dr. Yatin Mehta was mentioning, you can't have randomized control trials for parachute, etc. Yeah, so American Stroke Association is convinced because there is rapid improvement of many patients with this therapy and they are worsening when it is stopped prematurely. So they thought it's convincing proof of efficacy. So they gave a guideline which is class 1. Induction of hypertension is recommended for patients with delayed cerebral ischemia unless blood pressure is elevated at baseline or cardiac status precludes it. Coming to NCS recommendations, that is the Neurocritical Care Society recommendations, 2 questions were addressed. What effects does induced hypertension have on patients with delayed cerebral ischemia? Are inotropic agents useful for patients with delayed cerebral ischemia? So the recommendations are, patients clinically suspected of delayed cerebral ischemia should undergo a trial of induced hypertension. So they are also in favor of induced hypertension, and blood pressure augmentation should progress in a stepwise fashion with assessment of neurologic function at each map level to determine if a higher blood pressure target is appropriate. Again comes with strong recommendation. If patients with DCI do not improve with blood pressure, this is the Himalayas study group. Okay. So this study has been done in 4 centers in Netherlands and has been accepted for publication in Stroke. It's an RCT which was aimed to recruit 240 patients, but it was stopped in view of lack of effect on cerebral perfusion midway and also because of slow recruitment. Okay. When they aimed to get 240 patients, they managed to get 41 patients, of which 21 patients were randomized to induced hypertension and 20 were randomized to no hypertension. So what they found was, this was the primary outcome of the study, that is poor outcome at 3 months, that is modified Rankin score more than 3. That means patients have moderate disability that they have to be dependent on people. Well, in induced hypertension, 57% of the patients had modified Rankin score more than 3, whereas in no hypertension only 40%. Okay. So again, when you look at the last one, significant adverse events. Okay. In the induced hypertension group, 52% had significant adverse events, whereas only 25% had in the no hypertension had significant adverse events. So does that mean that induced hypertension is also questionable? Maybe in future. Okay. So they did not deter them from giving any conclusions. Well, the third H, that is hypertension, I am not sure. Well, time will tell. So the take home messages are, hypervolemia, yes, we have taken U-turn, now it's euvolemia. What about hypertension? Shall we go straight or take a U-turn here? Well, I personally would not make a U-turn here. Probably will wait for more big data in future. I will not go by that Himalayas study. Hemodilution, yes, definitely U-turn. Okay. Thank you.